Okay. Welcome, everyone. Thank you all so much for being here today. I'm Jamie. I'm with Metro Council. A little bit about Metro Council, just so you know. So we are all of the community mental health centers in the Kansas City Metro. So it's about 7 of us, um, 6, I believe, community mental health centers. Nope, 7 community mental health centers, and then a couple of other um, agencies as well that kind of fold into us. And so we all make up Metro Council, and we have a lot of education and training opportunities. And a big part of why we do what we do is collaboration and getting education and information out to our community. So we're so happy that you all are here today. And a couple of quick announcements before we get into our amazing presentation today is one is please save 2 different dates. In particular, please save October 17th. It'll be our in-person fall symposium at Johnson County Arts and Heritage Center from 9 a.m. to noon. And we're going to be focused on, the training is going to be focused on community trauma. So we're really excited for our keynote presenter, Dr. Jones with the Kansas City Public Health Department. She'll be our keynote. And then we'll also be having a panel talking about, again, community trauma and really what can we do around community trauma. So especially community trauma within the Kansas City metro area. So we hope that all of you can join. I will put our registration link in the chat. And with that, I am so excited to introduce Terri Cooley-Bennett. So a little bit about Terri, just so we all know. If I can get this to work. Hold on. Well, it is not working for me, but that is okay. I will just do what I know. So Terri is going to be talking about suicide prevention, behavioral health, and best practices today. And just a little bit about Terri. Terri's a licensed clinical social worker and a licensed specialist clinical social worker and a co-occurring disorders professional diplomat and a tobacco treatment specialist. She's a doctoral candidate at Tulane University School of Social Work and is employed by SWOPE Health Services as the Outreach Services Manager overseeing the homeless program. And her experiences include working with the Kansas City unhoused homeless population, and she has over 20 years of experience as a presenter, workshop leader, and educator, speaking for groups such as the Missouri Coalition for Behavioral Healthcare, Missouri National Association of Social Workers, University of Kansas School of Social Welfare Continuing Education Program, the Missouri Credentialing Board, SAMHSA, as well as many others. She also taught as an adjunct professor for the University of Kansas School of Social Welfare, provides field instruction for social work students. So quick little disclaimer before we get started. I'm sure all of you saw our little screen as we got started, but we say this for every presentation. So disclaimer, the views and opinions presented are those of the speaker and do not necessarily represent the opinions of Metro Council. But Terri is actually part of Metro Council. So real excited to have Terri today. And so Terri, you can take it away. Uh-oh, Terri, you're muted.
Okay. And can you see my screen all right? Okay, perfect. So I'm glad to be here today and speaking to all of you, and I love what I do. And actually, I had a job change, so I'm no longer the outreach services manager at SWOPE, but I'm a behavioral health intake clinician, and which is helps me out while I'm going to school. But just to give you that little update, but I want to talk to you today about suicide prevention, behavioral health, and best practices, and it's really important to me. And I can just remember years ago when I first started working with individuals who were suicidal, and how, that was just something brand new to me, kind of scary, kind of fearful, like, how do I handle this? What do I do? And back then, our main protocol was we called 911 immediately, and an ambulance would come and they would take the person away to a hospital. Things have come a long way since then. And it's prevention is now a very, very important part of suicidal, when we're working with individuals who may be suicidal. And I think way back, it was more of a just kind of like we weren't doing as much prevention. It was more of like, well, they're suicidal now, we need to do something about it. And so we've come a really long ways, and that's awesome. But I want to go over just a brief overview with all of you, just some statistics, just some numbers, a little bit about what are our definitions, what symptoms, what's some risk factors for suicidality. And also for those of you who are credentialed or licensed, you may, and we may have some from other states, but in the state of Missouri, we are required now to have suicide prevention continuing education units, because it's that important of an issue that even to renew our license, we do have to have these credits. And so it's become like a bigger topic now. But just to go over, like, what are some of the definitions? And so I have different sources listed on your slides and different definitions by different individuals, just to kind of give us a comprehensive understanding. This one, authors stated that suicide is a serious health problem. So it's viewed as a health problem. It's the occurrence of suicidal thoughts or behavior, which we all pretty much know that. And it's defined as death that's self-directed, injurious behavior with an intent to die. So sometimes, like in behavioral health settings, hospital settings, there's the issue of, well, was this intentional or not? Did the person accidentally take too many pills because they were just trying to get high, or were they intentionally trying to kill themselves? And I've been in mental health hospitals in an internship I had, and we had to determine that all the time, because it was going to determine how our treatment plan was going to go. Was this an intention to die, or was it not? It's also a big issue when it comes to cause of death. Whenever, like, a coroner's coming in to rule out what is the cause of death, there's always, was it an accidental thing, or was it an intention? And this affects our numbers a little bit, but in some areas, they're usually going to just say accidental death, because if they say intentional, then a lot of times families would not be able to get the life insurance money, because life insurance usually does not cover situations where someone completed a suicide. And so the death will be ruled as accidental, which that can affect then our numbers when we're trying to look at, well, what are the numbers? How many people have completed suicide in our state or nationally or wherever? So it is important, that definition, that it's an intention to die. An attempt is a non-fatal situation where a person was intending to die, but they ended up not dying as a result of the attempt. And suicidal ideation can refer to anything from thinking about or considering or planning suicide, to individuals that are just thinking, I'd be better off dead, or I wish I was dead, and things like that. Okay. And I'm going to try to, sorry about that. There we go. So, what is the most common risk factor as we think about what's some risk factors for individuals who may be suicidal? And if you want to type it in the chat box, you can. The type of webinar we're doing today. Not sure if we'll look at the chat box later, whatever, but just to think about, and you can see in the chat box, what do you think is the most common risk factor indicating someone may be suicidal? Would it be withdrawal from social contact, change in normal routines, or depression? And if you would like, you can put that in the chat. And I know I have access to it, but it's hard for me to see it with my PowerPoint up. So I'm just going to tell you the answers, but you can see what others have put in the chat. Actually, I do see it now. So we've got depression, we've got all of them, lots of depression, and just kind of a variety. So thank you all for who were able to put that in the chat box. The answer is depression is the most common risk factor. However, number 1 and 2 are still really important concerns. And those are something that if you do notice somebody's withdrawing from social contact, that's also something that's not really a risk factor, but it's more of a sign that you might want to look for and be aware of. If someone is withdrawing and finding out why and determining if it's because they're suicidal, but usually it also relates to depression, because if someone's depressed, they may be withdrawing from social contact. Okay, so what are some more warning signs that someone's suicidal? And I've just got a list here, and this one's from the Mayo Clinic. And like I said, I like getting lots of resources and just comparing, like, well, Mayo Clinic feels these are the normal warning signs, and others. So I've got that list on here for you. And also, by the way, I'll give access to the slides later too, if any of you need a copy or want one of the slides, if we're able to do that, or you can email me. But so of course, talking about suicide is a sign. And sometimes we think, well, if they won't be talking about it, but many times they are willing to talk about it when they are suicidal. And withdrawal from social contact is on that list as a warning sign. Feeling trapped or hopeless, increased use of substances. Some individuals have shared with me that they were hoping if they kept using enough that they would die because of their use, that they also will increase use. So that's a warning sign, like with because one of the populations that does complete suicide a lot is older men between the age of 45 and like 64, 65-ish, and then again, older men after the age of 75. And so sometimes you might see that an older man has, maybe he used to drink alcohol, but he's been clean or sober for quite a while, or he's, cut way back, just social drink or whatever, but all of a sudden you start seeing he's drinking more and more and more. So that could be a warning sign, something's going on here. He's all of a sudden drinking a lot more. So these are all signs, and it doesn't mean that just because somebody's drinking more that they're necessarily suicidal. It's just a sign that we want to be aware of and want to figure out, hey, what's going on? Why is this happening, and what's going on here? Of course, one of the signs is giving away belongings, like, having really special, important things that now you're giving away, or you want someone in the family to have, and giving those away. Saying goodbye as if you won't be seeing them again. So the individual who jumped off the bridge in San Francisco, and I'm going to give you his video as a resource later if you want to watch his story or hear his perspective about that when he jumped off the Golden Gate Bridge, which now they built barriers up that individuals can't do that. But he tells a story about how he hugged his dad and just said, "I really, really love you, Dad, and I'll see you later." And that was a sign right there, because he normally wouldn't like go in and hug his dad really tight and say goodbye to him. But his intention was to go jump off the Golden Gate Bridge. And so at the time, his dad didn't realize this was a warning or a sign that something was going to happen, because how his son was, hugging him. And so sometimes, like, we don't know, and I'll say not we, but as professionals, a lot of times we are aware of the signs, but like family members may not be aware of the signs, or they don't know that this is a sign to be aware of. So that's why we'll get into it later, but educating like family is really, really important. Um, we did that. I'm sorry, it goes backwards sometimes. So these are other risk factors, and these come from the National Institute of Mental Health. And some of the risk factors are depression and other mental disorders, which we're going to talk about later. Substance use disorder. Often it's combined with a mental health disorder. Anytime someone has a prior suicide attempt or a family history of suicide, family violence, and things like that, then those are risk factors. And so that's something we would screen for. Have you ever had a suicide attempt, or have you ever tried to harm yourself? And then firearms in the home is a really big risk factor. And there's a national, well, kind of a state, it started as a statewide training that I went to, that's training professionals how to talk to people about the firearms in their home, so that they can be either locked up or given away or removed or put away safely, because it's a big issue, is the firearms. Individuals who have been incarcerated, there's higher risk. And just like I said, the family history of suicide, but being exposed also to suicidal behaviors of others, such as family members or peers. And you may have heard, like in some of the high schools, where one high school student ended up completing suicide, and then later several others followed afterwards and completed suicide. So that's why it's like important to go into the school and intervene after a student has completed suicide, because the other students may follow. I mean, they may have already been thinking about it anyway, and now they see their peer has done it, and so they may follow and do the same thing. So those are some risk factors. And then other signs that may be reason for concern. And this is from the National Institute of Mental Health. And it's we've got a lot of similarities in the signs, but you could see a few different ones on here. Like looking for a way to kill oneself, such as searching online or buying a gun. I had an individual one time who told me he had found a way to complete suicide online, and he was describing it to me, and it was using balloons and other ways, helium and balloons and some other methods. And it was like a real elaborate plan, basically. And he had looked it up on YouTube and online how to do it. And so that was he was really high risk, and we ended up putting him on our risk list here at Swope Health. We have a risk list of people that we feel like are really high risk, that we check on more often and regularly, and we try to make sure that they're following up with psychiatry and getting the interventions they need. But anyway, he had actually was trying to find out ways, elaborate ways, other than using a gun or firearm. It was just other means he was looking up. And some of these others we've talked about already, but feeling trapped or in unbearable pain. I've had individuals who had severe pain and they just wanted to end it all so they could be out of their pain, and they didn't feel like they were getting any help with the pain level they were experiencing. Um, Being a burden to others. So that's when we get into people who are maybe older or disabled, or they've got a lot of issues going on and they feel like they're just a burden to everybody else, and that they're just a problem to everyone. Some of these others we've had said already: anxiety, agitation, behaving recklessly, like driving really fast and just being, inappropriate in cars and vehicles, and just being really reckless. Or maybe I've heard of like young girls like going for walks at midnight by themselves down an alley, down a street, knowing it was really unsafe or in a really unsafe neighborhood, but they're wanting to die and they're not caring at that point, and so they're just being really reckless, and doing things that are could be dangerous. Sleeping too little or too much, which is a sign and symptom of depression, but that could also be a symptom of they're just wishing that they weren't here anymore. And showing rage is something we haven't mentioned yet, talking about seeking revenge, just being very rageful over past maybe being abused, and extreme mood swings. Um, and I pointed this out to some other in some other groups where I've taught and everything, but it doesn't always mean they have a good mood. I mean, a bad mood, because I've heard several stories of individuals who completed suicide, and their mood switched all of a sudden from being really sad and depressed to being happy and upbeat. And one lady who shared her story, her husband brought her flowers, he took her out to eat, and she thought, wow, he is really getting better. He's feeling better, he's doing better, he's happy, he's going to work, getting up early, excited for work, going to work excited, coming home, being very loving, very kind. And then he completed suicide. Well, he went from being super depressed to happy because he had a plan and he knew it was going to end. His life was going to end. And he felt like it was going to be, for him, it was a positive thing because he wanted to end his life. And so his mood changed from being really depressed to happy. So just because someone seems like they're doing better doesn't mean they're really doing better. It may be they've just decided this is how I'm going to do it and it's going to work this time and nobody's going to know, and they're happy. And I've heard other stories about individuals that seemed like their mental health had improved, and they were happy again, but it was because they really were intending and had this plan that they felt was going to be successful to end their life. So we want to be concerned whether the mood is happy or sad, or if we see like a really big change in somebody's mood. That's another sign that could be a concern. And then certain populations are more at risk, and sometimes when I do longer suicide prevention presentations, I will go into the different populations and we'll talk a little bit about their characteristics and why they may be higher risk, and just some things, more statistics and things. But for now, I just wanted to give you a short list because there are more that could be put on this list. But adolescents, especially those with a depressed mood, individuals who have experienced domestic violence or really any type of violence, like severe childhood abuse and violence, transgender individuals, particularly those who are experiencing rejection by family or friends, or they've been discriminated against or victimized or experienced like a lot of violence. Veterans. And like I said, when I do the workshop, I'll go into more details, but a lot of times with veterans, it's when they like immediately after they've gotten out and they're trying to get back into society, trying to become a civilian once they've been a veteran. So there's like a window in there of when they're higher risk. Um, and it's usually when they come out, or sometimes like if their spouse leaves them due to their PTSD or their changes in behavior, and the spouse is not able to manage or handle the mental illness of the veteran. And then if the spouse leaves, that's another trigger. But there's different triggers that we're not going to go into all of it today. And then individuals experiencing homelessness, they already have a lot of distress compared to their general population. So they do have more risk for being suicidal. And then police officers and first responders. And then we have others on our list that we would go through at another time and not today, just since we only have an hour. Okay. And then our next slide is prevalence of suicide. So we're going to look at Missouri rates. So Missouri, the suicide rates have increased 29% since 2010. And sometimes it takes a few years to get our numbers together. So this is from 2019. And it usually takes a couple of years to get all of our numbers. And there may be some more current numbers that we can find or get to. But that was an important thing to know. And they also have been increasing nationally. So it has become more of a national problem because the rates continue to increase. Some more statistics is 4 people die by suicide every day in Missouri. It's the 9th leading cause of death in Missouri. However, when we look at the 10-year-olds to 17-year-olds, it's the 2nd leading cause of death. And the rates are highest among 25 to 64-year-olds. There was a little decline in suicide rates from 2018 to 2019. And Missouri suicide rate, the last I've seen, and I've looked at several years, I've been watching the number, but we were like 15th highest in the nation. And that's pretty high when you're thinking of 50 states, and Missouri is 15th. So that's why we're having a lot of prevention strategies. The state of Missouri is doing a lot of things to address suicide. And then we have different little groups like the group that's doing the firearms, trying to talk to Missourians about getting rid of their firearms. So it is a high number. These are just some older number. Well, no, they're newer numbers too, but from 1999 to 2010, when we look at that range, they increased. They've been increasing. The highest suicide rates, again, were among adults. I already said that. Suicide rates have been consistently higher among individuals who are Caucasian or white. Suicides did increase among Blacks between 2015 and 2018, but then it decreased between 2018 and 2019. There are consistently higher suicide rates among men or males than females, but there was a greater decrease in female suicides in 2019 compared to males. And so that was from the Missouri Where We Stand brochure of 2019, where they do these briefs on suicide in Missouri. and through the Missouri Institute of Mental Health. So they publish a lot of data. And again, we have to consider like where the data is coming from. Is it reported from coroners or from mental health centers, from hospitals, and what about those that aren't counted? Like where they're ruled, is it this was just an accidental overdose, or this was just an accident, it wasn't intentional. Okay. So means of suicide, this is another thing you could put in the chat if you'd like. But what type of suicide is the primary means or the most lethal type of suicide? And feel free to type your answer in the chat. Suffocation, which is hanging. So someone that hangs themselves, it's called suffocation. Poisoning is what is an overdose, basically poisoning from medications or pills or substances that they've used. It could even be alcohol or firearms. Okay. I'm just looking in my chat, so I'm leaned over here. Okay. Okay, so I'm seeing a lot of different answers. Okay. So firearms is the most lethal, which is number 3. A lot of you said number 3. And yes, overdose and poisoning is all of these are the primary ways that individuals attempt suicide or complete suicide, but the most lethal is firearms, because when someone does overdose, nowadays they can usually be saved. I mean, they usually don't complete suicide. They usually can be taken to the hospital and revived, and so they don't pass away, so it's not as lethal. And the same with suffocation. I don't think people hang themselves as much, but also they can survive a hanging. But if someone uses a firearm and is shooting themselves in the right place on their body, they won't survive. So that's why that firearms are the most lethal, because many times people will not survive if they use a firearm. Okay. So in 2019, 60% of Missourians who died by suicide did use a firearm, and 55% of all firearm deaths were suicides. So there were 5% of firearm deaths that occurred, but those were ruled accidental. They weren't suicides. And so that's a lot. And so that's why there is a big concern about individuals who own firearms. In 2019, overdose or poisoning deaths decreased by almost 55 since 2015. And males were more likely than females to use a firearm. And females are more likely to overdose or use suffocation, which isn't as big of a number. And then 61% of Caucasian men ages 45 to 64 and 84% of Caucasian men aged 75 and older used firearms to end their lives. So there is like I said, the firearm thing is a big issue to be aware of. And I know one of the main barriers is that individuals want firearms in order to protect themselves. And then the other barrier is individuals have firearms because there's a lot of rural communities in Missouri, the smaller towns and communities, the country, where individuals own guns to hunt. And I grew up with a family who were farmers, and they were all all my like uncles, cousins, all the men, they would regularly go hunting, and they all, they had multiple firearms so that they could hunt, and they would hunt deer and turkey and things like that, um, even squirrels and things like that. So um, that's a big issue because people do not want to give up firearms because they want to hunt, or they want to protect themselves, and there's a big concern about self-protection. So what's some of the national ways that individuals have um, used to complete suicide? Well, again, firearms was the most common method in all the suicide deaths in 2016. And this is from the National Institutes of Mental Health. And the national suicide numbers there, a lot of times it's hard to find like really, really current numbers. So, and there may be some 2017 numbers out, but 2016 was the last I had at the time, but there's also other sources that calculate that you can look up, but this is from the National Institute. And 22,963 deaths were from firearms in 2016. The second most common was suffocation, which is hangings. And there were 11,642 deaths by that means. And then poisoning was the third most common, and 6,698 persons died by poisoning. And as I said earlier, a lot of people don't die when they take pills or overdose. They're able to get them to a hospital and get them saved and revived. And I've talked to many clients that have attempted by using their medication or just taken all their meds or taken a bottle of ibuprofen, and they've survived. And some of them didn't even go to the hospital. They said they just felt really sick all day, but they survived. And then other methods is 3,662. So these are our national numbers. And so they're pretty similar to the Missouri as far as the number one methods and things like that. Okay. These are some case studies that I have on the PowerPoint, which we're not going to show today. Sometimes videos are difficult to do when we're doing a workshop and on Zoom, and they don't always come in good and they're delayed and everything. But I have them on the PowerPoint so that you can look at these later if you want a copy of the PowerPoint or you're interested. But there are actually lots of case examples on YouTube if you're interested or need them for educational purposes or training or whatever. There's just a lot of videos out there you get. This is some interesting research about why our suicide rates rising. Well, researchers believe there's an increased sense of isolation among Americans, as well as economic factors and a rise in mental illness. And of course, with the COVID-19, it was even worse, where there was even more people isolated because people were working from home and they weren't going out, and they were kind of isolated at home. And so because of the increased isolation, and nowadays, even in our society, like we don't know our neighbors, like, you may not even talk to your neighbors, and we're really busy. And we get up early in the morning and go to work all day and get home late, and then might have to stop by the store and cook dinner and take care of our little immediate family, and then maybe watch TV for a little bit or whatever, relax a little, get ready to go to work the next day. And so we're really isolated in our society. And researchers believe that could be a reason, but it is actually not proven. It's just a belief they have of that could be a reason. And some researchers believe technology could be a reason, or the rise of technology, and other researchers, of course, disagree with that. And so we have the 2 points of, well, technology has allowed for a lot of online bullying, especially among adolescents and teenagers. They bully each other online, they threaten each other online. I've met with individuals here at my work that were teenagers that were really bullied really badly online. Nothing could be done about it. One person even said their life was threatened. Someone said online, I want to kill you, I'm going to kill you. But because nothing had happened, the police couldn't really do anything. And there was just a lot of bullying among the teenagers using technology or messaging each other, text messaging with, saying things that are bullying and just really hurtful. And so that could be one reason. But on the other hand, technology's also been seen as a good thing because you can go to all these online support groups now. You can be anonymous and attend a group to get help for your mental health symptoms or for your whatever you might be going through. You can usually find some kind of online group to help with that. And you can also meet in the privacy of your home with a therapist online, virtually, and receive help that way, whereas you may not have been able to receive the help before. So it goes back and forth, of course. And then the CDC, Center for Disease Control, does report that some of the research does indicate suicide is connected to other forms of violence, such as the bullying, sexual violence, and child abuse. And so that is more of a researched topic, the violence issue. And there is a lot of violence. And where I work, every day I see somebody has experienced violence in their life, or someone they knew either was murdered, or just lots and lots of violence that I hear about all the time in my job with my clients. And it's really sad. And people are very, very depressed about it. Not everybody I see is suicidal because of the violence, but it causes depression, a lot of depression. So now we're going to talk a little bit about suicide and mental disorders. So just looking at which mental disorders are related to suicide. And I'm checking my time so that be sure we get through all our slides. But depression, substance use, and suicidality. So substance use, of course, can increase the chance of developing depression. There's even an alcohol-induced depressive disorder that an individual can have after using lots of alcohol. And I always assess to be sure that their depression didn't start way back prior to the heavy alcohol use, because you need to figure out, well, which came first. And but it doesn't really matter how the depression developed, whether it developed before the substance use or after, it's still depression. And depression also increases the chance somebody's going to use substances. And intoxication and withdrawal from substances causes depression. So naturally, two of the populations with the highest rates of suicide are those with depression and substance use disorders. So that's something to be aware of in your practice, is if someone's both depressed and using substances, they're higher risk. Major depressive disorder is the psychiatric diagnosis most commonly associated with completed suicide. So about 2/3 of people who do complete suicide are depressed at the time of their death. Then we have post-traumatic stress disorder. And that is where someone has experienced a traumatic event, and they can tell you about it. They can say, I've gone through this trauma or that trauma or whatever. So they have significant distress over the trauma, They may have flashbacks, intrusive memories. They may have exaggerated startle responses. They may have lots of things that point to that they have post-traumatic stress disorder. And if they don't have it, what I call full-blown PTSD, they may just have a trauma and stressor related disorder, which means they have experienced trauma and there's still some distress because of that trauma. But if someone does have PTSD, they don't usually overlap with depression. A lot of times, people with PTSD may or may not have depression along with it. But PTSD in itself is also associated with suicidal ideation. And anytime someone has childhood abuse, it increases a person's suicide risk. So just being aware that about individuals who have PTSD and the potential for suicidality. And this comes from one of the ACEs studies and from the National Healthcare for the Homeless, where they had an article written on homelessness and adverse childhood experiences, what are health and behavioral health consequences. And so there's evidence that if individuals have 4 or more ACEs, which is the adverse childhood experiences, which might be physical abuse, sexual abuse, emotional abuse, growing up with a parent with mental illness, growing up with a parent who is an alcoholic or used substances, or there's a whole list of ACEs. And anyone who has 4 or more ACEs are 2 to 5 times more likely to develop clinical depression, substance use disorders, suicidality, and of course other conditions. Then we have borderline personality disorder, and that's a pervasive pattern of instability and within and interpersonal relationships. And a lot of times individuals who do have borderline personality disorder have experienced that physical and sexual abuse, neglect, early parental issues. So they develop borderline personality. And so they end up, they have tendencies to be suicidal as well. And premature death from suicide may occur in individuals with this disorder, especially if they co-occur with depressive disorders and substance use disorders. So you can kind of see these different disorders are all kind of connected. As we look at, a lot of times there's also abuse involved, there's substance abuse involved, then we have depression. And so we can have like multiple things going on at one time that are going to give us an indicator that, hey, we need to be watching out for suicidality.
So Terri, we have a question about somebody said that they've been seeing the term unalived. Is that now the proper terminology?
Unalived. I have not seen that. I've seen the term, used to, we would say somebody, I've heard the word completed suicide. It used to be, we would say committed. And we got away from that word committed suicide. And we've used the word completed. So unalived might be a brand new word that I have not seen yet. And I have, I'm really blessed because I'm going to school right now. And so I have like endless peer-reviewed journal articles that I can access. And I've printed some out, and I have not seen that word, even in the new articles. So that's a new word for me.
And people are kind of responding right now in the
Okay,
chat.
good. Because
Yeah,
maybe other people.
unalived is being used by younger individuals. And I think, yeah, Gina's correct. And let's see, Lauren is correct. Darcy's correct.
Hey.
Larisha's correct. That, yeah, it's being used by younger people, particularly online, because then you can kind of get away from it doesn't get flagged. Um, so words like death and suicide get flagged on like TikTok and Instagram and Facebook, but unalive does not get flagged at this time.
Very interesting. I'm glad you brought that up, because that's another prevention strategy to me, knowing that the young people are using the words like that and terminology so that they don't get flagged. And so thank you for sharing that. I'm going to have to research it some more, um, because that's really, really important, that to know. And obviously I'm not young. And my kids are in their 30s. So I haven't heard it from them. Maybe someday I'll hear it from my grandkids, but my grandbabies are too little and my kids are too old. So, and I have worked with some adolescents here at SWOPE, and when I've done my assessments and psychiatric evaluations, and we've talked about, self-harm and suicidality and everything, but nobody ever used that word. So thank you so much for sharing that with us, and educating us, because we needed to hear that today.
And Terry, just letting you know, you got about 9 minutes left
All
if
right.
you want to kind of start talking about best practices.
Okay. So best practices is, and I'm not going to have you, I'm just going to run through this because of time. But what is best practices for suicide prevention? And the question is, screening all individuals for suicidality, or screening high risk individuals, or screening all teenagers for it? Our answer for best practices is we should be screening all individuals somehow, some way. Even in our medical clinics here at SWOPE, we do the PHQ-2 with them, just 2 questions asking about depression and suicidality. So that's something we really need to screen all individuals. And I know, like when I was in private practice back a long time ago, we didn't really do that, and then as it's becoming more of a prevalent issue, we really need to be screening everyone. It's a key part of prevention is identifying persons who may be at risk, which I've already talked a lot about that. But we also need to be collaborating with family members, friends, teachers, coaches, coworkers, anybody that plays a role with schools. We need to really make sure we're connecting so that we can find out, because a family member may be seeing signs all the time and not even know it. So educating society and families and schools and just different places is very, very important. There's many tools to screen for. It's important that we have resources in place and systems to connect anybody identified at risk to appropriate follow-up care and assistance. So it's not just screening. We have to have resources and systems there for follow-up. And that's super important. We have a risk list at SWOPE, and individuals who we feel are really high risk are on this list, and they are checked on weekly by a case manager, and they're followed and they're checked on, as well as we have them do, which I'm going to share. I'll say it in a minute, so I'll wait. So the ones that are more effective by the research is they follow up the suicide risk assessment with a comprehensive evaluation of the risk and needs. They share information about local resources that are appropriate for that population. They help build transitions and linkages in the community, and they share information about hotlines and other services. And this is a good video that it's on the PowerPoint. That's a good teen suicide prevention video. It's excellent. You could show to parents, to teachers, educators, groups, whatever. So when individuals suicidal and made an attempt, what's best practice? Number 1, develop a safety plan. Remove lethal means. identify trigger thoughts. Oh, this is a question, or all of the above. The answer is all of the above. We need to do all these things. We need to have a safety plan where there really are people they are safe with, they can contact. We, like if it's an adolescent, we have the parent in there and we all work together on a plan. So these are the best practices for treatment. This is just if somebody has attempted kind of similar thing about the safety plan, learning to live again. And then just vicarious trauma, we need to be aware of our own trauma. When we are working with individuals and we hear all these things on a daily basis about someone who's attempted suicide or whatever, it can be very traumatic, even for us as clinicians. So it's important that we have our own support system in place, which I've listed here from SAMHSA. And that's all of my slides. And then I have a couple of email addresses I put up. If you want to email me for the slides, I'd be happy to email you a copy so you can get those resources. I think we have like 2 or 3 minutes for questions, if there's any more.
There are a few questions. So any questions that anyone might have, you're welcome to put it into the chat or into the Q&A. Either one will work. There we go. So Stephen had a couple of questions. So the first one is, how do you involve family support without violating HIPAA?
Okay, well, you definitely need to get the consent of the person you're working with. And how I do it, I just say, I really care about you and I really feel like we need to involve your family in this. We really need to get them on board. And is it okay if I share with them and find out from the client exactly what they're okay with you sharing? Just because you bring a family member in doesn't mean you need to tell them all the issues about the client. It just means you need to say, I'm concerned about their safety. And this client has identified you as a support system. There may be family members that aren't supportive at all to the client. And so that's probably not going to be good to bring them in anyway. And so if they can have the client come up with, well, who's a family member or friend that I do trust enough to let them know how I'm feeling. I trust them enough to bring them in to this situation with me. If they say no one, that is a problem. So then we have to kind of think outside the box. But as long as the person gives you verbal consent and they're with you in the room, and like a lot of times with us, they'll even bring their family member in the room with us and give verbal consent that it's okay, their family members there. So that's how I get around it. I'm not suggesting that HIPAA overrides a duty to warn, but you need to know what your duty to warn laws are. And what I would do is I call, if somebody's going to hurt themselves, we call 911. I mean, I report it immediately. It don't mean I have to report it to their family, but I do have to report it because I'm a mandated reporter. So we work with the family together with the client, like I'm the intake clinician. So, and so I do all the preliminary, but I always try to bring the family in. If they're suicidal, the crisis team meets with the person, they do the safety plan, they contact people the client wants contacted. And so we try to really work it out. Okay, I'm trying to read some of the questions, make sure I get them all.
Another question is there a requirement that mental health facilities follow a best practice plan? And before you answer that, because I know we end in 1 minute, I will be putting in the chat the certificate of attendance, the link to get to the certificate of attendance, and the password to get to the certificate. So while you answer that, I will be putting that up.
Okay. So is there a requirement that mental health facilities follow a best practice plan? I know that there is some statewide efforts through the Missouri Department of Mental Health. There's suicide prevention strategies, that's best practices that you can go online and even read about it. I've been to some of their training. A lot of our staff have, and we've tried to implement things into our like electronic medical record as far as some of the suicide assessment tools. And like when you follow the tool, it kind of tells you what to do. And our crisis team addresses all of that. So the person goes to the crisis team. So there is a plan in place. You could look it up on the website. I don't know to the extent of it, like the mandate by the state of how, how and maybe some of you know that work a lot with your Department of Mental Health for the state of Missouri. You probably know more than I do, but you can definitely look that up online. But there is a big strategy, and we have a big strategy going on here where I'm on their suicide prevention team, and we're doing a lot of educating of our staff and doing a lot of stuff with all the staff at Swope, whether they're a medical doctor, the receptionist, no matter what they are, we're doing a lot of educating the staff.
Guys, I apologize, but it is actually time for our webinar to end. But I want to thank Terri so very, very much for her time today, for us being able to talk about suicide prevention. And thank you all so much for attending. So again, the certificate of attendance is located in the chat. Oh no, that's good to know. Thank you, Brittany. And please join us for our next webinar with Monty Miller on talking about the Great Resignation. So thank you all so much for joining today.